Scrubs and Clogs, a podcast brought to you by the Apprentice Journal, Faculty of Medicine, University of California, where experts scrub in to bring you the very latest in surgery.
Welcome to the podcast series brought to you by the Department of Surgery, Faculty of Medicine of the University of California. I'm your host, Pramod Chandrasinghe, Senior Lecturer in Surgery from the Department of Surgery. In this series of podcasts, we wish to discuss some of the important and interesting surgical topics to educate and enlighten our listeners. As the first of the series, we have a very interesting topic, Gall Stones, should they come out? And to discuss on the topic, I have here with me today Professor Rohan Siriwardene, Professor in Surgery and Consultant Hepatobiliary and Liver Transplant Surgeon from the Department of Surgery of University of California. Welcome. So, first of all, I would like to ask you, what are gallstones and how are they formed?
Pramod, yes. In our body, when there is a hollow structure or organ, we can get in all these places you can get stones, and one such place is a gallbladder. In gallbladder, basically for stone formation, there are two basic things. One, you need a solvent and you need a solute. So when we talk about gallstones, there are three basic type of stones. One is a pigmentous stone, cholesterol stones, and mixed stones. So for the stone formation, actually there are three things that can act as a solute. One is calcium, bile pigments, and cholesterol. Solvent is bile salts. So when there is a problem, when there is increased concentration of solute or reduced concentration of solvent, you get stone formation. So any factor, any condition which increases the amount of solute or reduces the concentration of solvent, you get stone formation.
So it is due to a supersaturation of one of the constituents in the bile. But are they normal, or in other words, do normal people get gallstones?
Well, having a stone inside your body is not a normal thing. But just because it is abnormal, it does not mean that you need to treat these patients. So I'm not sure whether you can actually call them patients, because it is so common. If you do ultrasound scans in 100 people, 10 people will eventually have stones. So just because you have stones, you do not become a patient. But you become a patient when it is symptomatic. So in simple words, just because you have a stone, it does not mean that you need treatment. But when it becomes symptomatic, yes, of course, then these patients, we consider them as patients, and then probably in these people we would offer some kind of treatment for these stones.
Any special conditions where people are more prone to get gallstones? Any diseases?
Yes. Now, for the stone formation, there are you can't say these are very strong risk factors, but there are predisposing causes. They may have a little bit of impact, but just because you have, let's say, for example, being a female, having high cholesterol levels in your body, and taking OCPs, having high BMI, these kind of predisposing factors, they may have a little bit of impact, but just because you are having this risk factor, that does not mean that you have a increased risk of developing stones. But there are certain other conditions like hemolytic diseases. If you, in these kind of patients, because they are in their body, because the hemolysis, the bile pigments are increased in the bile, and because of that, the bile gets concentrated, and they are at a risk of developing stones. But then again, you can't say there are strong risk factors for someone to develop stones, but there are probably predisposing factors. If these are there is a bit of a risk of developing stones.
Right. So importantly, there is a supersaturation And there are some people who are more predisposed to get this supersaturation, but the mere presence of gallstones doesn't mean that you need treatment. So these are very important principles. How would someone with gallstones present to you? In other words, in the outpatients, how do you detect people with gallstones?
More than 90% of the time, these patients comes to you. They come to you with the incidental finding, where they do ultrasound scan for something else, and then you detect stones in the gallbladder as presented as a asymptomatic or incidental finding. So that's the commonest presentation. So that's what we call these patients we call as incidental stone disease. But then there are three categories of patients or three kinds of symptoms where stones might give rise to three kinds of symptoms. The first symptom is a biliary colic. Now, biliary colic is actually a true colic where the stone impacts in the narrowest part, that is the Hartmann's pouch or the cystic duct of the gallbladder. And when a stone blocks the cystic duct or the Hartmann's pouch, the gallbladder tries to expel the stone and you get a pain. And this is a very, very, very significant pain that they develop. It's a sudden severe pain that they develop in the right hypochondrium and last for a longer period of time. And this is a very, very typical presentation. And patients, when you talk to these patients, you know that this guy had a biliary colic because they describe a sudden severe pain in the right hypochondrium, and you can't miss that. So that's one type of presentation of a symptomatic stone. And the second category of patients is cholecystitis. So most of the time what happens is the stone blocks the cystic duct or the Hartmann's pouch, and it stagnates the bile inside the gallbladder. And these stones, they contain bacteria, and as a secondary event, the gallbladder gets infected. And when it becomes infected, we call it cholecystitis. So these are two different things. Biliary colic, there is actually no infection. In biliary colic, there is obstruction and pain. It's a colicky pain. But in cholecystitis, the gallbladder is obstructed most of the time, but then there is superadded infection. So you get, apart from the pain, and the pain character changes because when there is cholecystitis, there is inflammation. So it's not a colicky pain, then it becomes a continuous pain, and the patient starts developing signs of inflammation like fever, generalized ill health, vomiting, and other generalized symptoms. And if you do infective markers in them, this will be increased. So that's cholecystitis. And the third category of patients is chronic cholecystitis, where in this category of patients, what happens is you have stones for a long period of time in the gallbladder, and the gallbladder, as a result of stones, there is ongoing or recurrent low-grade inflammatory attacks, which leads to fibrosis, and the gallbladder becomes fibrotic, contracted, and it has a thick wall. And these kind of patients are a bit difficult to diagnose actually because their symptoms are not very specific. They might present with vague symptoms, like most of them, they have symptoms overlapping. Gastritis or peptic ulcer disease or functional bowel disorders, where you complain of abdominal fullness, distension after meals, especially they can't tolerate fatty meals. These are vague symptoms. They have symptoms a long period of time. So its presentation is different because it's a long history, insidious history compared to biliary colic and cholecystitis. So these are the three common presentations, but then you can get complication of stones. Sometimes some of the stones they can pass down into the common bile duct. It can cause obstructive jaundice. So it's a complication of a stone in the gallbladder passing down to the common bile duct, and it can pass along the common bile duct through the ampulla of water. It can cause pancreatitis, so it becomes gallstone pancreatitis. So there are complications of gallbladder or gallstones. So these are the common presentation of stones.
Right. So basically, a majority will come to you with an incidental finding on ultrasound scan, and then there is the other group who get complications due to stones either obstructing the gallbladder, an obstruction and infection, or a long-standing inflammation that goes on as a chronic process, or when they obstruct the common bile duct or the pancreatic duct, you can get obstructive jaundice or pancreatitis. Now, When would you decide that a gallbladder with stones should come out? Do you take out all gallbladders when people have stones on an ultrasound scan that's incidentally detected? Or do you have a specific indication?
Yes. So, if the gallbladder, the stone is asymptomatic, it does not need treatment. So, asymptomatic stones, you don't operate, yeah, and actually you don't need to follow up also. And you don't have to, importantly, you have to reassure the patients because they are worried about stone because it is not normal. So they are very worried. So it's very important that you reassure this patient and tell them that this is extremely unlikely that this is going to be a problem. And you have to tell that even if it becomes a problem, that there are ways of sorting out these problems without any major complications. So these are for asymptomatic stones. Then if the stones are symptomatic, we earlier discussed about two categories of symptoms. There are acute symptoms, that is biliary colic and cholecystitis, and they have to be treated as emergency or semi-urgent conditions. Whereas if someone is having chronic cholecystitis, it's a routine presentation and you can manage them as elective cases. So asymptomatic stones does not need treatment, but symptomatic stones needs treatment. But there are very rare occasions that sometimes we might consider operating gallbladder even if it is not symptomatic. For example, let's say if you are operating a patient for upper GI surgery, like as part of another surgery, we might remove the gallbladder. Like in Whipple surgery, as part of that surgery, we might remove the gallbladder. And sometimes in areas where there is gallbladder cancer incidence is high, whether the gallbladder cancer is endemic. In these patients, if there are stones in the gallbladder, and probably we might consider prophylactic cholecystectomy. And sometimes in patients with recurrent acute pancreatitis attacks, if you can't find a cause, and if the patient is having stones, if there is no other cause, we might also consider doing a prophylactic cholecystectomy, even if we don't actually find, even if we don't know the gallbladder is causing pancreatitis, we might remove the gallbladder as a prophylactic measure.
Right. So importantly, asymptomatic patients do not need any treatment, and for the symptomatic patients, you need to attend. Or there may be asymptomatic patients with special conditions, such as increased cancer risk, that would require the gallbladder to come out. Right. Now, when you say cholecystectomy or taking out the gallbladder, someone might think it is going to be a major surgery. So could you briefly explain the surgical approaches that are available to take out the gallbladder?
It is actually one of the commonest operations that is done by surgeons, cholecystectomy. And it is actually not a major operation, it's not a major complex operation, it's sort of an intermediate operation, but it carries a very low risk mortality and morbidity. But having said that, it carries a complication. So that is why we do not offer treatment for asymptomatic stones, because when you weigh the risk versus the benefit, operating asymptomatic patients does not give a benefit or benefit to these patients. So there are two ways of operating the gallbladder. The traditional or the historical way is open cholecystectomy, where you make an incision in the upper abdomen and then access the gallbladder and then remove it. So that's a traditional open cholecystectomy. And the second method is a laparoscopic cholecystectomy, where you make access to the peritoneal cavity through the laparoscope, through the umbilicus, and you place another 2 or 3 ports and then do the surgery as a laparoscopic procedure. Now, there are a lot of comparisons that are done with open and laparoscopic surgeries. So when you talk about gallbladder operation, the most important complication that we should mention is, we should discuss is injury to viscera. And out of these injuries, the most important is the bile duct injury. But apart from that, other viscera can also get damaged, like the duodenum, which are close by, and sometimes small intestine, sometimes hepatic flexure, and these viscera can also get damaged. So these, but For cholecystectomy, people discuss about bile duct injuries because that is the specific complication for laparoscopic cholecystectomy or even open cholecystectomy. And if you look at the incidences of bile duct injury, open theoretically should have it has lower incidence of bile duct injury compared to laparoscopic injuries. But having said that, most of the time what happens is nowadays people open up when the laparoscopic surgery is difficult or when it is a difficult cholecystectomy. So actually nowadays when we open up, when we do open cholecystectomy we do for difficult cases. So there can be a slightly high incidence of bile duct injuries in these patients. So there are two approaches, open and laparoscopic, and laparoscopy has become the gold standard because it carries the recovery is faster, there is no complications related to the scar. So outcome is much better in laparoscopic surgery. But then we should be discussing about bile duct injuries because that is a specific complication for this surgery.
Right, so the preferred technique is laparoscopy or keyhole surgery, and if done properly, which has very good outcome and very minimal morbidity. Having said that, open surgery is also reserved for difficult cases or when there is a cancer of the gallbladder suspected. Okay, very briefly before we end up, a common question that patients pose to us is, are there effective non-surgical methods such as medication or shockwave therapy, laser, or any other method that has been proven to be effective to treat gallstones?
Yes, so that is a common question that is asked by the patients, and another common question that patients ask is, can you remove only the stones without removing the gallbladder? So basically, there are medications or drugs that people have tried, and actually it has shown to reduce the size of the stones, like ursodeoxycholic acid and chenodeoxycholic acid. You can give these drugs, and that has actually shown to reduce the size of the stones. But the problem is, when you stop this treatment, when you stop these medications, the stone will start forming again, and the disease is still there. So it is actually not recommended. Even ESWL or laser treatment, they are not considered as treatment for stone disease. And removing the stones is not recommended because you get stones because your gallbladder has a disease process, because your bile is lithogenic. Because you have exceeded the critical point of lithogenicity, and as long as you have the gallbladder, you get the stones coming again and again. So it is not an essential organ, and just because you remove the gallbladder, it does not affect your long-term outcome, and there are no long-term impacts on removing the gallbladder. So that has become the standard of care.
Right, so basically non-surgical methods are not effective in managing gallstone disease as far as we know. Right, so I think we had a very fruitful discussion on gallstone diseases. We discussed about the pathophysiology of supersaturation, and we discussed how patients present, and that gallstone disease is found in the normal population in about 10 to 15%, and also there are special predisposing conditions to give rise to gallstones. And then we discussed how patients present. Majority will be incidental, and then the others will have either acute or chronic symptoms and sometimes complications such as obstructive jaundice or pancreatitis. And we made it very clear that only symptomatic patients and those with high risk or special conditions, such as high risk of cancer, would require surgery. And the preferred method is the keyhole or the laparoscopic technique. And sometimes you might need to do open surgery. And also the non-surgical methods are not very effective for the management of gallstone disease. So I think we had a very fruitful discussion on gallstone disease, and I would like to thank Professor Rohan Sirivardhan again for participating in this podcast. And I'm Pramod Chandrasinghe, wishing you all a good day.